नमस्कार, मेरा नाम डॉक्टर विपुल गुर्जर। I am a professor and head of the Department of General Surgery in Sumandeep University, Vadodara. Today, I am going to upload this video, specifically most important and most effective as well as most dangerous technique and very demanding technique MIPH for the pile surgery. We will talk about its normally my experience rather than the teaching about this MIPH technique. It may be in one part or the two part also. Let's see how can I help you in your anorectal surgical technique as well as your practice. Now, whenever I have started my MIPH, definitely there was that much no videos available on YouTube also. So I learned from my friends, from my seniors. Then during the all the times, I was so much डरा हुआ रहता था कि इसमें कॉम्प्लिकेशन होगा नहीं होगा. Or many times, though it is indicated, because of this fear, I was not doing this MIPH surgery. Even sometimes I explain to my patient, this may be the harmful and this may create a problem. Please don't do. We will do the another technique. But with the experience of my fault, my the technical result I got, all now the all the funda is clear. So I will share all this thing to you. What are the problem with the MIPH? First most common problem may be the staple line dehiscence. इनएडिक्वेट डोनट. पेशेंट बोलेगा मीन्स हम सर्जरी के बाद हमें इन सर्कल जो राउंडेड डोनेट आना चाहिए वो नहीं आता है. और इट हैपन्स अ लॉट विथ मी. स्टेपल लाइन oozing, staple line bleeding, residual pile mass. After a 3-month or 4-month or 6-month follow-up, we will find out on proctoscopy there is a residual pile mass. It is not a recurrence, friend. It is not a recurrence. It is a residual pile mass. That means our MIPH has a no efficacy to reduce this pile mass or shrinkage of pile mass. Early post-operative pain, chronic pain, and staple line stricture. Now, what about my experience regarding MIPH? This MIPH technique is found by the Dr. Longo, Italian innovator, and he is present in one of the national anorectal group also. And with many times I have discussed with regarding the MIPH and other technique also, and he is a wonderful person and wonderful innovator. MIPH is one of my most favorite technique for the pile surgery because it affect the common problem of prolapse. I think piles is not a disease, it is a symptoms of rectal prolapse. In other technique like hemorrhoidectomy, laser surgery, or other any technique, we are dealing with the only the pile mass. We are not dealing with the prolapse, which is main problem of the disease, and the constipation. See, once your patient is coming to you in OPD, what are the problems? First problem may be the bleeding and the prolapse. Then you will ask, what else you have? He will say, sir, I have a constipation. I am not able to pass stool easily. Now, after surgery, we always looking out our surgical procedure. That means a proctoscopy, and we say, yes, pile mass is gone, pile mass is gone. So we become so happy. But have you ever asked to the patient that your constipation is relieved, yes or no? We are not asking, because we are taking the pile mass as a disease. No, pile mass is not a disease. It is a symptoms of the rectal prolapse, and this MIPH is partly or in a more like in a larger amount also. It resolves some extents or the major extents about this prolapse also. So there is a some there is a big issue about learning of this prolapse and constipation, but we I am not going to that much depend in these lectures. We will definitely go in another lecture series regarding this topic. And with my experience, I am not doing MIPH alone in many cases. I will definitely recommend the hybrid technique. This is my experience. This is my thought, because I want to give the 100% result about the cosmesis, about the regression of bile mass, and about the disease of constipation. So I am recommending the hybrid technique in many cases, that means MIPH with the hemorrhoidectomy if required, and if patient is explained about the pain. MIPH with the laser if patient is explained about this condition, or else also, or you may go with the MI star rather than the MIPH. This is a hybrid technique for the pile surgery. So after this explanation of everything, we are taking this patient to our OT. Then what is the most important problem when we are starting the any anorectal surgery is the loaded anal canal. So once there is a loaded anal canal, your surgical field is smashed. I recommended MIPH is a resection and anastomosis. Whatever we are taking care of, any resection anastomosis, we should take care in this case also. That prevents a submucosal abscess, clean, neat and clean, and surgery, as well as a less infective profile. That means I recommended the colonic wash prior night to the surgery. If it is not happen, and many times it is not there, we are forgetting, or it's not our routine practice to give the colonic wash for the pile surgery, then how to deal with the peroperatively. So now how to deal? Take a TUR set, 1 liter saline, and as a, like a, in a we are doing a TURP. This TUR shape tip we insert the anal canal in different mode, different angle with the help of speculum, not the anoscope, with the help of speculum. And in this time, during this, we ask anesthetic to give the head up position, so this fluid will not go in the colonic part. So whenever it happens, this saline goes in the colonic part, patient feels urge to pass out in early post-operative time. So it is better to wash out all the irrigation what we have given during the anal wash. So the TUR set speculum is your instrument for the anal wash. Now, after this cleaning of anal cavity, most important step is to prevent a complication, and the better surgery is the CAD fixation, that means known as a circular anal device. And this device is given by all the companies, and it has a rounded working space and 4 centimeter depth that goes inside the anal canal. This 4 centimeter is useful to safeguard the uh, pile mass, and it is also 4 centimeter in range. That means the our suture lines remains above the dentate line. If you are faulting this, your technique is faulty for the CAD fixation, your complication is 100%. For the stricture, bleeding, chronic pain, everything can be happen while if you are not doing the CAD fixation properly. Now, how to do the CAD fixation? There is a anal dilator is available with the MIPH set. Put two finger, apply the first anal xylogen jelly inside the anal canal. Stretch one finger posteriorly to relax the sphincter. Put the two finger inside the anal dilator, then push slowly inside the anal canal. Slowly, why? Because otherwise it tears the mucosa and it gives us some oozing. So slowly insert the anal dilator and then rotate slowly. Wait for 1 minutes at least, so that relax the sphincter complex to accommodate the CAD. Now after this, you take a CAD over the dilator and try to push this CAD with the push technique inside the anal canal. Now I said, oh, you can ask me, what is a push technique? Oh, push, there is a two technique. One is a push technique and second is the pull technique. That is, I am explaining in easy way technique for a CAD fixation. Initially, I was using this pull technique for the easy CAD fixation. In most case, whenever the smaller height of patient, the CAD may not go inside the anal canal easily. So the peoples or myself, I was using that I was taking a suture at anal verge 12, 3, 6 and 9 o'clock position, or I was applying the Alice retract. Then I insert the CAD. Then I was used to fix that previously taken anal verge suture with this CAD angle. No. This is not an ideal technique for the CAD fixation. We have to fix the CAD over the perianal skin, not the anal verge. Because once you are fixing with the anal verge, after this resection and anastomosis, anal mucosa will go inside, and this anal verge suture with the CAD that keep pulling, and that makes the staple line in a tension. So I recommended you fix perianal skin for the CAD fixation. Yes, sometimes in a male patient we are not able to insert the CAD, then you can apply the pull technique with the Alice forceps and then insert the CAD and then release the Alice to accommodate the CAD in proper. Then you take a perianal suture fixation. Now what? This is okay. At this stage also, I have to remove my previous suture. I have to reinsert further CAD. Why and where? If I am not able to see only rectal rectal mucosa, only rectal mucosa inside the CAD. That means if I am able to see the pile mass, some white structure or the some anal skin in a CAD, then the CAD is not properly fixed. It means this is below the dentate line. So make ensure that you must see only rectal mucosa in a CAD, nothing else. Otherwise 100% complication. Now after the CAD fixation, should we start with the purse string suture? No. Even in my OPD also, I explain to my patient, I will take a decision about my appropriate surgical technique per operatively. So this is the time for the decision making which technique is we should go for the pile surgery. Then I'll do the swab test. What is swab test? After the fixation of CAD, you will see inside the rectal mucosa. Take a large bowl of gauze piece and make it some jelly or some lubricant and on the swab holder. You push this swab inside the rectal mucosa and then slowly pull this swab. If the rectal mucosa is coming up to the distal margin of anal CAD, there is a two margin. First is a proximal margin and second is the most outer margin is a distal margin of CAD. If your mucosa is retracting itself with the swab test up to the distal part, that means this is a not an ideal case of MIPH. This is a rectocele case and you must go with the star procedure or you abandon this MIPH surgery. Otherwise patient will come back to you with the persistent constipation and obstructive defecation syndrome after the surgery. So this is swab test. It is peroperatively differentiating test between the MIPH and the star or ODS, etc. So now we after this all this step we have decided about the MIPH procedure. We are going to start with the MIPH procedure. See, the suture material which many companies are giving with the set of stapler, but many companies are not giving. Please ask them to provide the suture material, that is 26 or 27 cutting needle polypropylene suture material. Please do not use other suture material, otherwise you may have some oozing and less piercing and your restricted movement while the purse string suture. Now another problem of our problem is the inadequate donate. Now this is a time how to resolve this problem. So I start the suture line from where? In a third part, the stapler company is provided is the half plastic anoscope. This is a half slitted anoscope and there was a marking inside. Many companies start from 1, 2 and 3. Many companies start from below 3, 2 and 1. We insert this anoscope inside the CAD. So then your rectal mucosa becomes so straightened. Your working surgical working field becomes straightened. After this putting in this anoscope inside, you take a cautery coagulation mode at the some 50 or the 10 watt a machine and mark multiple marks in a circular manner at the between distal part between 3 to 2 is your choice. Between 3 to 2, you cauterize, make a marking, cautery, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. You mark this cautery. Then you start with the suturing. How to hold the needle? If possible, please use 7 or 8-inch, 7-inch needle holder. Then you will be provide a long this 27 or 26 polypropylene suture material with this device. No needle hand or one end is fixed with the distal or your drap, and grabs needle at the somewhat thread part, that means between 1/3 and 2/3. The 2/3 is the proximal part, distal part of the needle. Start from the 3 o'clock if you are a right-handed. If you are want to start with the 6 o'clock, I don't mind, you can, but I am experienced with this 3 o'clock position, so I am starting at the 3 o'clock where I have marked my cautery. Take small bite, not a large bite, a small bite. Use a wrist movement to negotiate needle, mucosa and the submucosa. Take this bite. Sometimes many people ask me, सर स्पिंक्टर आ जाएगा तो कैसे पता चलेगा और हमें कितना डीप लेना चाहिए? देखो, अगर आप स्किन म्यूकोजा ने सब म्यूकोजा में हो तो आपका जब जैसे ही पियर्स करते हो थ्रेड, फिर आप जैसे पुल करोगे तो म्यूकोजा ऐसे पुल होगा. अगर आपने डीप बाइट लिए और स्पिंक्टर फाइबर आ गया है तो वो म्यूकोजा पुल नहीं हो पाएगा. डेट मीन्स यू हैव टेकन सम स्पिंक्टर पार्ट. So it is a less chance because this needle is 26 or 27 size. So it is very, if you are doing so much forcefully, then it is possible. Otherwise, don't worry. Take adequate mucosa and submucosa. Sometimes because of this fear, you are not taking you are taking a superficial bite, and this superficial bite may cause oozing, tear of mucosa while this closing the device, or sometimes it causes early stricture. So please don't fear about the deep bite. Take a adequate bite. Start 3 to 4, 4 to 5, 5 to 6, 6 to 7, and around the clock. You may have a difficulty when you are taking a suture over the 11 to 1. Okay, so while taking this suture 11 to 1, your wrist movement must be like this. Take a needle holder and like this. So don't do like this. It should be a wrist movement with the needle holder. Okay. Now, once you are reaching at 9 o'clock, you have started from the 3, then you are reaching up to the 9 o'clock. Then wait. So after reaching to 9 o'clock position, you wait. You ask your assistant, please give me 10 prolene suture material. So he will give you the suture material and make a loop of that suture. That means your two end must be with the artery forceps, so it make a U shape, a loop. Then your purse-string needle must pass out through this loop. Okay. Then ask assistant slightly keep taut your this extra suture, so it will not hamper your surgical field. Then you continue your purse-string suture up to 3 o'clock position, and please beware about your previously cautery marking. So at the end you will reach at the 3 o'clock position. Now what? Why we have taken 9 o'clock extra suture? This is known as a counter suture. See, many times after taking this purse string suture, I was not able to pull the suture because it may get locked in the mucosa and submucosa. So after this using a counter suture, I take this counter suture in my hand and the completed purse string suture in my hand. Then I will pull like this. That means a shoeshine manner of our hiatus hernia surgery. If we are able to do this like this movement freely, that means your purse string suture is free. Then ask for your assistant to give further your endoscope and further push inside in multi-direction. So because of this shoeshine procedure, your purse string became a tighten. So your device may not go inside. So to make adequate, you further applied endoscope in multiple direction. Now do not pull this suture. Now take a device. Open. There is a opening the device like this on behind the machine, and there is a knob. So you open on the anti-clockwise direction. So your proximal part of device come out. You apply the xylocaine jelly and push slowly inside the endoscope beyond the purse string suture line. Please wait. I have forgotten one more thing. Before this inserting device, you apply your finger to check a purse string suture line. If you are palpating exposed proline, that means you have not taken the mucosa of that part. Then remove purse string further and take another purse string. Okay? Otherwise, it will not go inside the staple line and it will create a problem. Okay. So further go ahead. We insert the device beyond the purse string suture line. Ask assistant to hold this device downward direction and do not move left or right and with the relaxed position. Ask assistant don't pull your counter suture also. Then yourself, your purse string two hand suture, pull like a shoeshine manner. If it is moving well, that means your purse string is good. Then you tie. While tying, you ask your assistant just move device towards the left shoulder of the patient. That means it will give more space to insert your finger inside the CAD. Okay. Then take a 5 suture knot adequately tighten. Okay. Then also ask your assistant do not pull your counter suture at this time. Then your ask assistant to come back in the middle position. Then you yourself please stand up. Okay, there is a one part is giving by the companies is a thread puller. Okay, so in a device there are 4 holes available: 12, 3, 6 and 9 o'clock position. You stand up, then take a right hand your purse string suture in your hand. Sorry. Hold your purse string end with your left hand. Then pass thread puller with your right hand in a 3 o'clock position and pull this thread outside. Same way, on the left side, you hold thread with the left hand and pull with your thread puller. So with your counter switcher. So now 3 o'clock and 9 o'clock position, you will have a purse string and your end of 2 thread, and 9 o'clock the 2 end of a counter switcher is coming from the device. Ask your assistant, do not move like this. Keep steady movement. Then you take a loose surgical knot of these 2 thread, your purse string end as well as on your counter suture. Apply artery forceps. Take a gauze to artery forceps tip so it won't hurt your finger. Then you stand. You close your device slowly, and while this closing, you pull this thread outside. That means you are pulling the mucosa inside the device, and you continue with closing of this device till you visualize a green line marking over the device. If it is happen and adequately tight, wait for the at least 3 minutes. This is my practice. I believe with this 3-minute waiting, all the fluid in the mucosa and submucosa will disperse. So after 3 minutes, you remove the safety lock. Then fire with the one force. Do not fire one like this. In the one shot only. Wait for the 30 seconds after firing this device. I believe that waiting of 30 to 45 seconds after firing, it will decrease the oozing. Because of this compression, this small oozer may not come in a picture. Then you just half rotate the device, and then rotate the whole device 180 direction and slowly you pull. If it is not coming easily, don't worry, don't pull. You open the whole device, so you will able to see the tip of device and the CAD margin which is clashing each other, and you definitely remove the device adequately. So do not fear about this whole opening of a device. Okay. So after this firing a device, you immediately put a small wet gauze inside. Then check your donut about your circular and the size. It will be a circular one with this technique. If it is not in circular, then also please do not afraid about anything. You observe the stepper line. That means remove your previously put gauze with your plain forceps. Take your plain forceps, put xylocaine jelly and half anoscope and observe the whole staple line. If it is broken, staple line is broken, if then what? And if it is oozing from the staple line, then what? Please do not afraid. If there is a oozing, put the saline wet xylocaine jelly gauze piece over the oozier part and wait for a few minutes. Mostly, in most cases, this oozing will stop. If there is a bleeder, that means a spurter, then do not hesitate to take a suture. Oozing is somewhat different and spurter is somewhat a different thing. If there is a bleeder, then you have to take a figure of 8 suture. How to take this figure of suture? Please use 27 mm VIPUL 20 suture meter with the 5/8 circle. It will helpful for your curvature. And use curved needle holder 7 or 8 inch long. It may help you to hold the suture adequately and to for your wrist movement. So take a proximal bite and go crisscross manner, that means X manner. Okay, take a first suture, hold both the thread in your hand, pull some, then take another bite. This pulling of thread will help you. And do not tie with the needle holder, use your surgical knot. It will be a more easier manner. Then sometimes many doctors asking me, should we take a stay suture at 3 7 3 9 11 or 12 o'clock position? Initially I was using about this stay suture. You can take, there is a no harm, but with the experience I do not get that much importance about this taking a stay suture. Sometimes many people asking, if you are taking a suture, if you are burying this staple line, some many people, or I was using to burying this staple line inside the mucosa. Uh, Many people was asking, okay, how the staple line will shred off. Yes, I don't know how it will shred after this burying the staple line. But in my practice now, I am not taking a stay suture because it is somewhat difficult, as well as there was no much difference in my practice. So I am taking only the purse string suture. But yes, if you are initiator and you have done a good number of 20-25 number of MIPH, please start using 3, 6, 9 and 12 o'clock position stay suture. It may help in your emergency condition. That means once there is a bleeding occurs, this suture technique will help you, this experience will help you to control this bleeding.